All right, welcome. Welcome to STAT's virtual event, Protecting Residents of Nursing Homes from Pandemics, sponsored by AARP. Thanks for joining us. I'm Matt Herper, Senior Writer for Medicine here at STAT, and in just a few moments I'll be joined by several experts to discuss the impact of the coronavirus pandemic on long-term care facilities and what we can do to protect residents and staff at these facilities going forward. We've got a lot to talk about. First, a few housekeeping items. At the bottom of your screen, you should see a few icons. There is a chat icon and a Q&A icon. Use the chat feature to chat amongst yourselves or to send a message directly to the STAT team. Do not put your questions for us in the chat. Instead, if you do have a question, and I hope you do, please use the Q&A feature to type your question over to us, and we will try to answer it live. In the Q&A window, you should also be able to see the questions that other attendees have asked, and you can upvote the questions you would most like to see answered. Thanks again to all of you for being here. Before we get started, I'd like to first welcome Bob Stephen, Vice President of Caregiving and Health Programs at AARP, to open today's event. Take it away, Bob.
All right, thank you, Matt, and thank you all for joining us in this timely and important conversation today. You know, to date, almost half of all the COVID-19 deaths in the United States, that's more than 55,000 people, have been residents in nursing homes. And cases continue in these facilities to grow. These are our parents, our grandparents, our spouses who have passed away, often without being able to see or say goodbye to their loved ones. And some of their families may not even be aware of their deaths yet. And that's both tragic and unacceptable. We've heard from thousands of family members who are worried sick about their loved ones. Many have gotten no updates. They don't know if their loved ones or the staff are safe or sick and haven't been able to properly grieve their loss. And they're outraged. And no family should have to go through what these nursing home residents and their families are going through right now. You know, many families across our country have trusted nursing homes and residential facilities to care for the people they love when they no longer can. But clearly, too many facilities are poorly prepared, understaffed, or lacked a plan to help loved ones communicate with residents, despite the best intentions of staff, operators, and overseers. So AARP is advocating for more effective, timely, and consistent data on the infection rates in facilities. We're advocating for more protective equipment and testing for staff and residents, and also safe visitation plans, particularly as states now are beginning to open up. But the immediate crisis is forcing us to confront a bigger problem. You know, our country is aging, and there is no effective long-term care system in the United States. Our long-term care facilities are severely taxed, and demand is only growing. And you just imagine what the future is going to look like with no meaningful change. You know, right now, filling the gaps in the long-term care system are more than 48 million Americans providing unpaid care to their family members and friends. And even before the pandemic, these families provided, as I said, the bulk of long-term care in the country, and it's extremely costly to them. You know, many family caregivers look after their loved ones, whether at home or in a facility, and they're providing more than 20 hours of care per week, often with financial costs to themselves and also at the neglect of their own health. So it's not enough when this is post-COVID. We return to a patchwork system of public and private supports for people who care for aging and ill loved ones. We have to seize the moment to create meaningful, sustainable change, whether that's in state and federal policy or business practice and community response. You know, we need much better care options, whether that's in nursing homes, assisted living, villages, multi-generational housing, home and community services are brand new models. It's going to be important that we have things that are designed for both the safety of the residents, but also their quality of life. And at the same time, we have to be addressing the disparities that this pandemic has really laid bare in terms of the quality, cost, and availability in care, particularly among those in multicultural audiences. So at AARP, that's what we're fighting for on behalf of all caregivers, families, both current and future, and their loved ones who need care. And so again, I thank you all for being part of this very important conversation, and I'd like to turn things back over to Matt.
All right. Thank you, Bob. Now I'd like to introduce the featured speakers for today's conversation. Dr. Grace Jenk is the Associate Clinical Professor of Geriatric and Palliative Medicine at the University of Michigan. Dr. Morgan Katz is an Assistant Professor of Medicine at Johns Hopkins University School of Medicine. And Dr. Rachel Werner is the Executive Director of the Leonard Davis Institute of Health Economics and Professor of both Healthcare Management and Medicine at the University of Pennsylvania. They've all written on this topic, they've all thought a lot about it, and I think we're going to have an amazing conversation. Thanks to all of you for joining me. I'd like to remind everybody and encourage everyone. We've got a few dozen questions in the queue, but I'd encourage you to add more and to go in and like the ones that you want answers to. And I'd like to get started by asking Dr. Werner, this problem has really struck us in the COVID pandemic, but as Bob was saying, we've got a lot of years of neglect in this system. Can you speak a bit to the bigger picture here of how we got here and why this played out the way it did?
Sure. So I think what we've seen over the last 4 months in this country has been an absolute tragedy, and the loss of life in nursing homes has been one of the most difficult things, I think, for many of us to watch in this pandemic. But I don't think that we should be surprised that this has happened. There have been decades of neglect of nursing home finances and nursing home policy in this country. It's resulted in a nursing home industry where nursing homes are largely marginalized. They are often insufficiently monitored. But the main problem is that they are underfunded. There's no sustainable and systematic way to pay for long-term care for our loved ones in this country. As a result, we've, as a country, built a long-term care system where nursing homes have faced low levels of funding and decreased funding in recent years. It leaves them on a good day with little financial reserves to invest in quality improvement, to improve the care of that they provide to the residents in their facilities. But then when something like the pandemic hits, nursing homes have no reserve to address that problem. The pandemic required significant attention to providing PPE to staff and residents to try and decrease the spread of the virus. It needed sufficient testing to identify the virus, and nursing homes didn't have the finances or the ability to invest in it in a way that could have really slowed down or prevented the spread of the virus within nursing homes.
So Morgan, tell us a bit about what that looked like for you. You were closer to the front lines here in terms of...
Yeah, so just to give a background, I have been doing research on infection prevention practices in nursing homes and really ways to make this feasible given the limited resources in this setting really since the beginning of my career. So when I first heard about this pandemic, I was immediately very concerned. I think there's several reasons why this was such a tragedy in nursing homes, and they struggled with it so much. So one, you have a vulnerable population that requires constant hands-on care from staff, and they're in a group living situation. And you're also in a setting that, unfortunately, due to limited resources, a lot of these infection prevention practices have been overlooked for many years. So I was called by the Johns Hopkins Incident Command early in the pandemic after one of the nursing homes in our catchment area sort of essentially folded because they didn't have enough. They had so many sick staff members and they were not able to take care of the residents in that nursing home anymore. And when that happens, there's a surge into the acute care setting. So I think that the acute care hospitals really started to understand that this is our responsibility too. This is a shared patient population, and we needed to start helping to stand up these nursing homes. So the first thing we did is really started reaching out to the nursing homes, set up a team that would go out and provide widespread testing to the nursing homes. At that point early in the pandemic, and still, unfortunately, in a lot of places, nursing homes are only afforded testing for symptomatic residents, which just really is only capturing a part of this picture. We saw so many different resource challenges. One was the testing, the PPE issues. We would have to drop PPE to nursing homes that didn't have it available even to get through the weekend. And then on top of that, major staffing shortages. So there were a lot of things that these nursing homes were struggling with, and I think they felt very much alone, particularly early on.
So Dr. Jenk, again, what did you see facing this in Michigan?
Yes, very similar to what Dr. Katz was saying. Very early on, we had to partner with our local skilled nursing facilities. I think nursing homes that are affiliated closely with academic centers stand a better chance of being able to test rapidly because one, our University of Michigan had the capacity to be able to test our local skilled nursing facilities where our faculty were actually taking care of patients. That collaboration between an academic center, a hospital, along with the skilled nursing facility and laboratory testing is absolutely essential. And I think moving forward, as we are going to have to continue to manage COVID, you have to have that type of partnership. So yes, we had a very similar situation as in Baltimore. However, I think because we were able to jump on that partnership and essentially start communicating on an hourly basis, we were able to contain our infection rates in our local skilled nursing facilities and really be able to dampen down our mortality rates. And so, I mean, I think we have to keep thinking about what we're going to do in the future. Like Dr. Werner said, I 100% agree that we do need more funding. We need to have better partnerships and collaborations. And I think we need to change the culture of the nursing home. So I've spent quite a bit of time in the hospital setting over the last 20 years. And the hospital setting has really turned into a learning organization where mistakes or errors that happen to patients in the hospital are reviewed very carefully. It is a non-punitive environment in the hospital setting, and it is one in which we learn from our mistakes and we try to improve. And I don't really see that in the nursing home setting, and I think everybody on this call really needs to advocate that nursing home settings should really be transformed into a learning organization. It shouldn't be about citations and penalties and firing of nursing home administrators and directors of nursing and turnover of the frontline staff. Every time you do that with a citation on a survey, the memory of the institution's gone and you have to start all over again. And I think if we can get away from surveys being punitive and really expecting nursing homes to have infection control specialists, and that just recently happened, that there was a federal mandate to say, yes, we need to have a dedicated infection control specialist. If we can make sure that the surveyors actually review how the facilities are actually going to change their processes, I think we'll stand a better chance rather than citations and surveys where really heads just roll when that happens and there's no good way of learning.
Dr. Katz, does that match your experience?
Absolutely. So, I think particularly in this pandemic, there were survey activities where, and a lot of times where mandates are coming, but they're coming without the resources that the facilities are actually able to carry them out. So it's easy to tell a facility that they need to wear gowns for every single episode of patient care, but if the gowns simply aren't available, they are not able to do that. And so survey activities 100% need to be paired with the resources, with a learning collaborative experience, and really giving, I feel like so many of the staff and administrators felt that they were sort of sitting on their hands in the pandemic and waiting for the local health departments to drop them the test or tell them what to do, but giving them some autonomy to have tests on hand, start to respond to those rapidly, perform some of their own contact tracing so that they can actually feel like they're a part of responding to this. I know so many of the administration felt very frustrated because they were doing everything they could to obtain the resources they needed, but just weren't able to do that because of the limitations.
Dr. Werner, why is this system the way it is? In a few minutes. But.
Yeah. Nursing homes have an interesting history in this country. I don't want to go back too far, but for many years, nursing homes were unregulated or had relatively little regulation in this country. In the late 1980s, that changed to increase regulation because there were a lot of stories about nursing home residents being neglected and poor quality of care and that kind of thing. Despite the large increase in regulations that occurred over the past few decades, quality of care in nursing homes hasn't increased all of that much. It's improved somewhat, but we have a long way to go. I think part of the issue has been well laid out by Dr. Katz and Dr. Jenk, and there's a culture in nursing homes that is not amenable to improving quality. There's also a lack of funding to really invest in and improve quality.
And people are underpaid in this.
Yeah, and so part of the funding issue is that the staffing within nursing homes has been a problem for a long time. In the pre-COVID era, staffing was a problem. Now with COVID, it's even a bigger problem. Staff are underpaid. And some of the lowest paid workers in the healthcare industry work in nursing homes. They're often undertrained. And so even in the COVID era where we can give PPE and we can direct funding towards nursing homes, there really has to be technical assistance and help on the ground given to nursing homes to respond to the directives that are being given. I think we've seen far too many unfunded mandates during COVID, but even if they were funded, it needs to be more than just money. We really need to get on the ground and help nursing homes respond more effectively to COVID pandemic.
I want to get to some more of the viewer questions. Some of them are heartbreaking. This one is from Hazel Weiser, and it's one that I think we saw in a lot of questions that were sent in beforehand too, which is, will there ever be a time when we can affordably and safely care for patients again in a skilled nursing facility? And I think when I hear that, I wonder, what can we do now, given that we're seeing cases rise again across the country? What steps can we take with these systemic problems? It makes me feel kind of hopeless looking at cases rising so quickly in many states. What can we do to protect patients now? That can be for any of you.
So from a big picture standpoint, the nursing homes that we have seen hardest hit during the COVID pandemic are the nursing homes in counties with the highest rates of COVID infection. And so it's not a problem typically of bad apples within the nursing home sector. It's a problem of their high rates of coronavirus infection in the community, which are inadvertently being brought into the nursing home. Part of the reason it's spreading so rapidly within nursing homes is there are vulnerable patients within nursing homes, but also the setup and the architecture of nursing homes, the industrial nature of nursing homes has not helped. And so I think we need to think about depopulating nursing homes and make them more single rooms, more home-like settings that will be less amenable to the spread of these infections.
Dr. Katz? What have you?
Yeah, so to add to that, I mean, I think, first of all, these nursing homes really need one clear universal set of guidelines in terms of best practices. I think the nursing homes that I've seen succeed are the ones that have everyone wears universal, at least face shields and masks in every single facility, regardless of patient care, regardless of patient status, COVID or not. And then beyond that, having testing capabilities is going to be really important in terms of thinking about reopening. Surveillance, at least of the more high-risk residents and staff members that may be traveling between active outbreak facilities and other facilities. We've seen a lot of transmission between facilities because of staff members that are required to work at or have to work at several facilities really to pay the bills. And then on top of that, just making sure that they have the resources that they need available, PPE, And this pairing with acute care hospitals, I think is a short term and potentially long term, but I think it's something that we could put together quickly to help stand up, particularly some of these nursing homes that are not in larger chains and really don't have anyone to reach out to for infection prevention guidance and some of the other resources they need. So that's something that can be put together pretty quickly. And I think those are sort of short-term solutions to get through at least the next several months.
Grace, what in the short term can we do? How do we get through the next few months?
Yeah, I think things are going to rapidly change, and like everybody has said, we're learning. Everybody's learning. I think there needs to be federal guidelines that help the local communities figure out what to do. I don't think that we're going to be able to continue to have no visitors allowed long-term. There have been a lot of chat comments as well as Q&A comments that people are not going to just die of COVID. They're going to die of isolation and other comorbidities that quite often family members or visitors will pick up faster than any of the nursing staff. And so when we don't allow visitors in, we are putting our vulnerable elderly population at risk because they just don't have the attention that they have had in the past. That being said, we have to have more ability to do this rapid testing, and there are some new testing strategies where you can get a test result within an hour. And these type of testing tools are not readily available for the skilled nursing facilities, but I do see a day coming where visitors can get tested at the door, or they're going to say, you know, I'm going to come to see my mom today and get tested that day, and within an hour the result will come back, and then they will be able to enter the facility with proper PPE and still some distancing just to make sure that everything's okay. I think we'll get to a point where nursing homes will be allowing visitors to come, but we need better testing strategies for that. And I also believe that you can't treat every community the same. So if there are places in the US where there's a high spread of community COVID, then yes, I think the facilities will need to remain locked down. But if you're in an environment like myself in Ann Arbor, Michigan, where the rates of infection are very low, then there needs to be opening of the skilled nursing facilities with protection. Everybody still needs to wear the PPE, where we can be a little bit more flexible. But I think we need to have a little bit more, we still need a lot more literature in this area to be able to say, is it 5% infection rate in the community that will, or less, that will allow the nursing homes in that area to be able to open up? Is it going to be, if it's 5 to 20% that we are not going to, or we have a different type of process, and 20% and above, then no, we're going to lock down the nursing home. We have to have some type of gradation in terms of visitor policies that hopefully will come out in the next several months. You're on mute.
Yep. Dr. Katz, Dr. Werner, the question we are getting the most is this question about how do we get to see family members who are in nursing homes. Again, it's the top question from Wendy Simons here. What suggestion do you have for engagement and support? I have great worry about the social emotional needs of nurturing people's body, mind, and spirit. How soon can we get to a point where people can see their family members again?
So if we had adequate testing and adequate PPE, it would be much less of a concern to let visitors into the nursing home. I think there's been multiple problems from the lack of visitors in the nursing home. One has been brought up related to isolation and mental health concerns related for the residents. I think another thing that is often unaccounted for is that caregivers come into the nursing home and really help the staff and help with feeding and help with other activities in the nursing home that can improve the quality of care and the quality of life for the nursing home residents. And that's not happening anymore. On top of that, nursing homes are short-staffed because of the infection. We could have caregivers tested and have one or two people per resident come in as and continue their role as caregivers and visit their loved ones in a relatively safe way if we had adequate testing for them.
Yeah, I would say I'm, especially now in the summer, really pushing outdoor visitation when you can make it happen. I feel like right now we sort of have an opportunity to get some of those outdoor visits in a safe, you know, we have at least some evidence and literature that outdoor is safer than indoor. So even doing a 6-foot, some type of park visit, if they have an outdoor situation, I am recommending to facilities that are in a low community prevalence area to try and do that with masks. I think we do have an opportunity to try and do that now, especially while we wait for testing to get ramped up, because right now, obviously, the whole country is sort of, again, struggling with a backlog of tests now that things are starting to reopen. So hopefully we won't have to wait until we can test that quickly for residents to start seeing their loved ones again, if we can utilize the outdoors a little bit more.
I'm not used to unmuting. For Dr. This came for Dr. Jank to comment on Governor Whitmer's mandate to discharge COVID-19 contagious patients from the hospital directly to nursing homes. But we've seen it a lot with relation to Dr. Cuomo and with Andrew Cuomo, Sarah, and other states. What do we think of this? Has this been a problem, or does this need to come from the community?
Yeah, it's a real challenge about what to do with, number one, if patients are infected in the nursing home, go to the hospital for care, and have to go back to the nursing home because that's their home. Is that safe for all the other residents in that facility? So that's one challenge, is what do you do when their primary residence is that particular nursing home? Is it safe? I don't have a great answer for that. I don't know if we have enough studies out there to show that if you have been a primary resident nursing home, you go to the hospital and you come back to your primary nursing home, if you are going to spread it to other members of that nursing home facility. Hopefully, now that we have more PPE and that staff are much more aware of how to make sure that administrators can have certain wings of the nursing home where patients can return to, where there's a COVID wing and those patients can be isolated from the rest of the community. Hopefully that reduces the amount of spread, but it's hard to say whether the spread in the nursing home happened because of these patients who came back from the hospital or whether it was coming from the community. And there were visitors or there were staff members who were bringing it in. Very challenging to say. Now, if you have a community person who lived at home, went into the hospital and is so debilitated and needs to go somewhere for rehabilitation, that's a different story. Should nursing homes be forced to take these patients? That's also a major challenge. If there's a COVID wing where there's dedicated staff, dedicated PPE and testing, then yes, that's a possibility. But most of the nursing homes struggle mightily to have COVID wings because it is just that much more resource intensive to be able to dedicate beds for these patients with COVID. And it's also a major challenge as to when patients with COVID can come off of precautions, meaning when can they leave their room and when can staff members not have to wear the full garb. It is still a major challenge because there's no good way to say, there are two strategies by the CDC. You can go by symptoms and a timeline of greater than 14 days and you just come off. It makes people very nervous just to take people off precautions just based off of symptoms and time. But if you keep testing patients in the nursing homes who have had COVID, they quite often will come back positive over and over again for weeks to months at a time. And so getting patients off of the precautions is a big issue. So if you can't do the COVID wing, there's the thought of having these COVID hub sites where these are dedicated facilities that only take COVID patients. And long-term, that may be a strategy as to contain this so it doesn't, you don't risk having this intermingling of sick patients with non-sick patients. But every state is a little bit different about this. And I'm curious what Dr. Katz and what Dr. Werner have to say about this.
Yeah, so we did set up a COVID-only hospital in Maryland, and it was very helpful in terms of being able to discharge some of those acute care residents that needed acute care patients that needed post-acute care but didn't necessarily live in a nursing home before they went to the hospital. And also really, I mean, I think a lot of the challenges in the nursing homes and something that's so important is cohorting the staff, because we see entry a lot of times and from asymptomatic staff members. I mean, that's been one of the biggest drivers of entry into nursing homes. And I know we all sort of at the very beginning of this pandemic had this idea that we could just keep it out, right? By doing this screening and being really careful about our infection prevention practices. But now we have, you know, such a more robust understanding of the risk of the asymptomatic spread. So being able to cohort into either an entire nursing home that's COVID only or really being able to section them off could be a helpful strategy. It's just, we got one open and I'll tell you it took months of policy work and a lot of phone calls. So we just have to make sure that we figure it out and know how to support that process.
So I don't want to be a contrarian, but every time I walk into my hospital, they check my temperature. And every time I think to myself, I could easily be getting COVID and have a normal temperature because we know there's tons of asymptomatic carriers out there. And I think that in nursing homes, if we only focus on what we do with patients that we know are COVID positive, we're going to miss the boat. I think that we need to set up nursing homes in a way that every single patient is treated with universal precautions, and we think of everybody as potentially a COVID infected asymptomatic spreader. I think COVID only wings are important, and I think they provide a level of reassurance, but if we're only worried about keeping COVID out of the nursing homes, we're going to miss the boat. We need to worry about stopping the spread of COVID within nursing homes.
You mentioned about Governor Whitmer and her executive order. She also just had an executive order about 2 weeks ago that all nursing home staff must be tested weekly by nasopharyngeal swab for COVID in order to be able to enter the facility. So addressing this whole asymptomatic spread, now myself and my colleagues are all having to be tested on a weekly basis. It is no fun at all. And I pray that there is a different type of strategy that has high sensitivity rates pretty soon, because I'm not sure if my NARS are going to be able to tolerate this. But I think we have to do this in order to protect our patients and our residents.
Do we have enough tests and PPE to do this, though? I mean, especially given we're still seeing a lot of tests come back 4, 5, 6, 7 days later if you're not actually at a hospital.
Right. And that's the difference between the testing capabilities. So at an academic center, you will see that the turnaround time can be a day. But a lot of the nursing home staff are being asked to go find your own way of getting tested. And if you go to Rite Aid or CVS, it can be days to weeks. before you get your results back. So that's a big frustration. And I think that locally here, we're still trying to figure out the best way to do this.
Exactly. I think you're
Go ahead, Dr. Bell.
I mean, I do think a feasible, like you both said, I think something that we could actually institute right away is really this mask and face shield, both for all patient care activities. That's something that you can wear extended use. And, you know, I think there's been so much devotion to the gowns, which I think are probably less involved with transmission than the mask and face shield. And actually what most facilities have struggled the most getting, in my experience. I don't know if those have been your experiences as well. But really, if we had those sort of instituted for all activities to start, I do think that would help a little bit. And I totally agree about the testing. My concern is that, you know, we finally got the facilities up to a point that we could promptly go and universally test every facility once they had an identified case. And now that we have this mandate that the staff is tested once a week, which I totally agree with if we have the resources, now that we have that mandate, that now our tests have gone back to taking 5 to 7 days to return a response. And then we lose our ability to do this effective contact tracing. So really having some centralized process and an understanding of the lab capabilities behind all this is so important. And we just have not figured out how to get a central view of this.
What happens during flu season? Jenny Cannon asks.
I'm hoping.
That's a very good answer, Dr.
I'm hoping that flu is not going to spread through our facilities. One, we need to absolutely make sure everybody gets vaccinated for flu. And then two, if we can really continue with our aggressive PPE, maybe we will not see an outbreak of flu as well. But you know, the laboratory testing are going to be strained by this dual testing of flu and COVID at the same time. We had problems with that initially back in March when we were doing dual testing, and it was a strain on our laboratory capacity.
A big picture question from Barbara Hopcraft. I've studied the long-term care system in Scandinavia. Providers told me that the biggest problem the US has in providing care is that our system is primarily for profit. Can you respond to this? There are a bunch of questions asking, is this all because we have a for-profit system?
Well, so it's certainly true that we have a predominantly for-profit system. In the studies that have been done to date, for-profit nursing homes haven't looked particularly more vulnerable to COVID infections than not-for-profit nursing homes have. Over the long term, that may change. And it's certainly true that historically in the United States, for-profit nursing homes have lower quality of care than not-for-profit nursing homes. I don't know that that's the fix here, though. I think there's we have a highly contagious virus that we don't have enough equipment and protection to contain. And I think that's a bigger issue at the moment.
A lot of questions coming. One here from Jonathan Rosenblum about any guidance for residents of assisted living facilities interacting with each other outside of nursing homes. And also, I think embedded in this question, nursing home residents interacting with each other so that they're not in total isolation.
Yeah, I mean, I think
two separate questions really there, but I think they're both good.
Yeah, I mean, I do think assisted living has been overlooked a little bit in this process, and they still are very important. And I think that they also had a lot of the issues with more of the issues with PPE for sure in the beginning. Those were the facilities that we were doing more of the emergent drops of the PPE. In terms of residents interacting safely, I mean, I think really keeping with some of the reopening guidelines. Again, this is going to be based on community prevalence and in the surrounding community, and no active cases in the community with really active monitoring. They can potentially start opening up facilities to, have 3 or 4 or 5 residents dining, dining room together, sitting 6 feet apart, or residents going outside to spend some time outside. Just really thinking about the activities that are going to pose the lowest risk of transmission, but still allow them to interact with one another and get some fresh air and time out of the isolation room. I have seen a lot of, different practices that facilities have done to try to brighten their days, concerts in the hallways or outside the windows, and various games that they'll play through computer with the families. And none of that for sure takes the place of actual physical contact, but we are going to have to start being creative about brightening their days a little bit.
A question from Jessica Lee. How do you see the role of home health care changing throughout COVID-19? Is virtual home health care a suitable alternative for the elderly that have that option? Can some people stay at home longer maybe, and should this be leading to that?
Yeah, so I think that that's a great idea. I think that one of the things we've learned from the COVID pandemic in nursing homes is that perhaps the home is a safer environment, and that many people actually prefer to stay home rather than as long as possible, rather than going into a nursing home. There have been many demonstrations and many research studies showing that home is a very safe place to be, and that we can have very intensive, like post-acute care, even hospital care occurring at home. There's no reason we can't have chronic care occurring more effectively at home. With the loosening, Medicare has loosened regulations on use of telehealth, and that has enabled people to stay home longer and for people to go straight home after hospital discharge and get the care that they need, which was more difficult prior to the loosening of the telehealth regulations. And I really hope that that's something that continues after the COVID pandemic is over. And I think that we need to spend more of our long-term care capital on home-based care.
Another interesting question here from Rich McCary, who says he's an executive in the healthy buildings movement, and asks basically, is part of the problem the buildings? Is it things like air filtration and fresh air ventilation and the presence of a lot of recirculated air without good filtration or purification? Is that part of why nursing homes have been so hard hit? Does anyone have a thought on that?
I think it's possible. I don't think we have a lot of clear research in that regard for me to give a definitive answer on that yet. When I have been advising nursing homes, if they can increase their air exchanges, I do recommend that. It is challenging with air conditioning running in the summer constantly. But yeah, I mean, there have been places where I have had the facilities open their windows if possible. So any type of way to increase ventilation is helpful. And I think, as Dr. Werner said, we are starting to look at the need for single rooms in many of these homes. It's a challenge now, really because of funding and physical space, but it probably would improve our response to these infections significantly.
But it is, as Dr. Kess pointed out earlier, it is important to note that this looks more and more like an airborne disease. And part of the reason being outdoors is so much safer is because of the much larger amount of air circulation that's happening outdoors. So to the extent that we can mimic that inside, it probably makes it safer.
A comment from Susan Hughes that she doesn't find it helpful for us to be talking about nursing homes collectively. And in particular, there's a bunch of distinctions drawn here, but one that I thought we haven't touched on is the difference between long-term custodial care and disability care, which is shorter and the patients are coming out more quickly. Should we be making a distinction, and should there be more distinction made between those facilities when we talk about regulations and rules here?
Go ahead, Rachel.
So the nursing home industry is like a very odd industry in that it provides two very distinct types of care, as you've just pointed out. One is custodial care for people who can't live independently on their own over the long term, and one is short-term care for people discharged from the hospital. Typically, those that have been mixed within a single nursing home. I suspect moving forward in the future, we're going to see those things separated more. There's not a good reason for them to be delivered in the same place. There are financial incentives that have caused that to happen, but I think it would be safer for patients, probably better quality of care to separate them. And I think then, when we worry about the spread of infection from post-hospital discharge patients, it would be less of a concern in that case also. But I think it's a good point that we've been sort of lumping them together, but they are two very distinct populations of people.
Yeah, we lump them together because financially that's the only way they can survive, is that they need the rehab patients and the payment system in order to help with the long-term care patients who are primarily Medicaid. It's a real challenge. I do think we're going to see a separation physically. I think you're going to see that patients who are being discharged from the hospital are going to go separate location, and then the long-term care custodial are going to be isolated in a different area.
Okay. Now I'm going to go to each of you and ask if there's one thing, one solution, either that we have or haven't talked about that you'd want to highlight before we go, because we're running up to being out of time. So I'll start with you, Dr. Werner. Is there, if you're stuck in an elevator with a governor and you've got until you get to the 5th floor to give them a message, what is it?
I think that we need to increase the funding that we provide for long-term care. I think we need to provide stable funding across the spectrum for all people who need long-term care. I think one of the things we haven't talked much about today are the disparities that we've seen in long-term care, and that vulnerable, people who come from communities of color and low socioeconomic status have really been hurt differentially in the COVID pandemic in generally, but also is the case within nursing homes. And so I think it's a reflection of the lack of funding that goes to facilities that are in poor neighborhoods, and that we need to level the playing field and provide more funding across the board to prevent this kind of crisis from happening again.
Dr. Katz.
I think that the thing that has really struck me from being on site in a lot of these facilities is how demoralizing it has been for the staff that are going in these facilities every single day, and not feeling like they have the resources and that they have someone lending them a hand. And I think that nursing homes have been portrayed in a sort of a rough way, in that they're not doing what they can. And I know that a lot of the staff and the administration have struggled with this significantly. So I guess the one thing I want to say is that any policy that comes really needs to be guided by available resources, that these mandates cannot, no mandate that we're going to give should be unfunded. And really providing safety culture and lending a hand to the staff in these facilities is really the only way that we're going to improve this process, and making this collaborative and forming private-public partnerships is the only way that we're going to improve and actually be able to respond to this appropriately.
Dr. Jack?
Lastly, I would want to say be kind, and that the heroes of the healthcare system there are a lot in the long-term care and in the skilled nursing facilities, and they go unrecognized. You hear about hospital heroes, etc., but you don't necessarily hear as much about what happens in the nursing home. So be kind. If there are people on the line today who have family members in long-term care or in the skilled nursing facilities, please do be kind to the staff. They are trying their hardest to do the best job. And they, for the most part, do love your family members. They go into this not for the money. They go into this because they really love people. And they like to take care of those vulnerable folks. So I would say be kind, and I agree with Dr. Katz and Dr. Warner. If we have mandates, they must have come with support as well. And I'm just hoping and praying that we have better treatments coming soon, that we have better testing strategies that are coming soon, and that we can continue to maintain our high level of PPE and precautions, because this is such a unique disease that is spread so rampantly. We have to have our guard up at all times, and I don't think that's going to go away for a long time. So we need everything altogether.
And just a quick question to all of you. Is there enough PPE now? Is it available enough, especially if we see another surge?
I asked my governor's office that this morning, and they told me in Pennsylvania there's so much PPE going to the nursing homes they're having trouble storing it. So I don't know.
Dr. Katz?
I think it depends on the facility. I think they need to watch really closely. I would be cautioned to say that, but I have, from the facilities I've spoken to and the state health department, we seem to be in a better place. I would say gowns continue to be an issue.
Dr. Cenk?
I think it's state by state. And I think that in Michigan, I think we are better prepared now. However, the distribution strategy across the US, I think is a bit of a mess. So I think I'm cautiously optimistic, but I'd be nervous if we really do have more of a national surge.
All right. With that, I think we're about at time, and we're going to wrap things up. Thanks again to all of you. This has been really great. I really enjoyed hearing what each of you had to say. And thanks to our sponsor, AARP. Keep an eye out for more STAT virtual events happening soon. And until then, everyone, please be safe and be well.